Welcome to Phoenix Rising with Dr. Z. This podcast is all about conversations about healing and rising from the ashes of your grief and trauma. I'm your host, Dr. Christina Zampatella. It is my sincere hope that this podcast is going to give you the words and the understanding to help you heal through your grief and trauma. All right, well, here we are. Hi, everybody. Welcome to Phoenix Rising with Dr. Z. Here we are speaking with Dr. Angela Dean, who I had the honor of meeting just about a few months ago.
Yeah.
But apparently we were sisters in a previous life, and so I'm okay with that. We're just going to start out today, and she'll introduce not only herself, but the topic we're going to be covering, which I am excited to be able to approach because it's one you guys have been asking me to cover, and it's one that is near and dear to both her and my hearts. So welcome, Angela. And who are you? Tell us who you are.
I'm Dr. Angela Dean. I'm a psychologist and thanatologist, which I don't know if your listeners know. That's the study of death, dying, and bereavement. I work primarily with individuals who are grieving, whether that's loss from death or chronic illness, which is what we plan to talk about today, and caregivers. I'm also an adjunct faculty member at Chatham University, where I teach grief and grief counseling, and I've taught mindfulness counseling along the way. I don't know what else to say about myself. Yeah.
This is your third career, you said?
It certainly is, yes. Prior to this, originally I was a set designer in theater.
Oh, a set designer?
Set designer, yes. Fun fact.
So different than okay.
It's actually not, because you have to understand how characters interact with their, I get that question a lot. So you have to understand how characters interact with other characters and their environment and what their motivations and behaviors are. So it's really not a far cry from psychology.
Never looked at it that way.
Not
That's pretty cool.
Real people, right?
They're projections of people.
Exactly. Fun fact, though, while I went to Carnegie Mellon here in Pittsburgh, and I did a little work with Mr. Rogers' Neighborhood while I was in college.
No.
Yeah, it was my work study job, so I got to do props for their show through the university.
Did you find his shoes? Was that's the gig?
No. So in Pittsburgh, you grew up here, everybody gets to go see the studio. We all got to see the shoes and the whole thing. Yeah.
I had no idea. Well, that's cool. That's a cool thing.
Yeah.
He was pretty cool. I don't think people knew how cool he was.
Yeah.
He was actually an important figure.
Yeah. He actually, before he died, worked on the grief center here in Pittsburgh, the Highmark Caring Place. He helped open that up for children's grief. And,
yeah. Well, I learned something new today. All right, cool.
Yeah. I don't know what his role was. I just know that there are speeches that he made and things. After that, I worked in IT. Totally different. I was good at it. I didn't love it. So here we are. I'm a psychologist.
And you just switched to psychology. How did you end up switching to psychology?
Yeah, fun fact. I thought I was going to work with the victims of human trafficking. But then I realized that's mostly trauma work. And I wasn't ready for that because I learned while I was working at a grocery retailer's IT department. I learned it was sort of IT and it was sort of buying at the same time, between the buying and the IT department. I learned about tomato farmers who were being trafficked. And I was like, I just want to help people get out of that situation.
Wow.
Yeah. So.
I've never heard a story like that, where the way somebody got into their career was recognizing the actual suffering and trauma of people through agriculture.
Right.
Yeah. That's amazing. Well, I'm glad that you're here.
Yeah. I mean, I grew up in a grocery store, my grandmother had this whole like 20 questions she would ask her clients and get to know her customers, and was really just a very loving, kind human being.
Hmm.
And she made everyone feel heard and connected. So I think I've carried that through all of those strands to what I do now.
That
Yeah.
makes sense.
Yeah.
So, um, are you working in private practice right now?
I do. I own a group private practice. I started this private practice in 2020. I was working in a cancer center at the time during the pandemic. Not long after my own brother died unexpectedly, and there was a lot of grief and non death loss work that I was doing in the cancer center. But we were also seeing clients. I'm way going off on a tangent,
No, you're
but
fine.
we were seeing clients with telehealth, which was rather new and sudden in the work. We were seeing them all the way up until the day that they died. I was a grieving human, as most of us are, but I was in the early stages of grief and seeing dying people on their deathbed, which prior to that, cancer patients typically don't see their psychologist at some point. If they are dying, they can't come into the center. So this changed the way that we were working, and it, with productivity expectations and being asked to see so many people and seeing so many people in those end stages of grief, it became too much. So I wanted to jump into private practice where I could do other things, control my work life balance a little bit more, especially around grief and loss.
It's a lot of intense kind of grief and trauma work to do. It sounds like you were like tuning into yourself and trying to find, like, yeah, no, this is where my boundary is, and you
Yeah.
adjusted accordingly. So tell us a little bit about it. You know, you and I were talking about, well, what topic do we want? Because my God, the two of us come up with a litany of them. How would you like to approach our conversation today about chronic illness and actually weaving in caregivers, as you mentioned, because a lot of people, a lot of my listeners want to talk about that as well. So where would you like to
Yeah.
go with that?
Well, I can share a little bit personally. Chronic illness has been in my life for my whole life, whether it was a cousin with a rare genetic disorder or my grandmother who had cancer for 40 years. And so that was always there. I never really shied away from it. And then I met my husband. He's my second husband. As you've recently said, collecting husbands was just kidding. He was a cancer survivor when I met him. And then at one point he told me that nobody had asked him how he was doing while he was in his cancer treatments. From a psychosocial oncology perspective, nobody really checked in with him.
What do you mean by that? Not everybody would know what psychosocial means.
Oh,
What do you
I'm
mean?
sorry.
That's okay.
So psychologists, social workers, helpers that are not physicians working in cancer centers
So they
or
wouldn't ask
cancer
him how
care.
he was doing?
He did not have any interactions with those individuals.
Oh,
So
okay.
his physicians weren't asking, like, how are you doing emotionally with this? It was, let's get you through the illness, get you to a survival state. Lack of care for quality of life seemed like it was his experience from what I know. That was way before I met him, so I didn't know that. And so when I was in grad school, not realizing I didn't want to, or didn't, not that I didn't want to, that I didn't have the capacity to work with human trafficking victims, this kept coming up for me. Like, what would that be like to understand cancer care in this way? And so I was introduced to the association. No, sorry. It's the American Psychological. Let me try that again.
Try it again.
American Psychosocial Oncology Society, APOS.
Oh,
And
didn't even.
from there, it's super small. It's
Mm,
like smaller than ADEC, I think.
okay.
There I learned about Jimmy Holland. She was one of the psychiatrists at Memorial Sloan Kettering. She was the very first person in the 70s to say, hey, we need psychiatrists. We need social workers checking in with cancer patients. Her husband was an oncologist. And if it wasn't for her, the stigma around cancer would still be similar to what it is with mental health. And so I learned a lot about that. I started studying more of how cancer care did or did not support the clients, and wrote a dissertation on caregiver distress, and started like every practicum, every thing that I could do. I ended up working with chronic illness patients or caregivers, which, as you know, comes with a lot of grief and loss. And so it's naturally been a great fit of the things that I do here in my practice, which are mostly caregiving, caregivers, chronic illness patients, and grief and loss of people and all of the non-death losses. I don't think I answered your question. I think we went over here and I
And
didn't
we're
come
going to
back.
take, we'll get to, I
Yeah.
like scenic routes. I think they're interesting. You
Okay.
never know where you're going to go, but that's fine. So in, so we have chronic grief, right? And chronic loss, and we have chronic illness, but then we have finite losses, where cancer often can, if it doesn't go into remission and the person, we have an understanding that that likely is going to be a finite loss. We all have finite loss. You know what I mean? We're all going to die. Got
Right.
it. Don't want to talk about it. Fine. Stick your head in the sand. I don't like it either. But that difference, help people understand what it's like. Okay, hold on. Let me see how I want to ask this question. If I had a chronic illness, which I do, I have epilepsy. So that's a chronic illness. I had a potential life-threatening illness, the cancer. So like I am living with both, right? But there's a different feeling between the two of them, at least for me. I'm wondering, in your experience, what do you notice in regard to the difference between what might be a terminal illness and what is more of a chronic illness, and the definitions of those?
Right. So I'm no expert on the definitions, but if we think of those the non-terminal illnesses, not to say that you couldn't die from something like epilepsy, of course, but the illnesses where they may have a longer trajectory or a better prognosis than other illnesses. I think mortality, or the idea of like, how am I fearing my own death, it's there, but it's less pervasive than those illnesses where there is a terminal end of life is discussed, right? The prognosis is poor. We might stop treatment. We know that our death is sooner than later. I feel like those two things do feel different as far as when clients are sitting with us trying to understand, what does this mean? How do I live with the illness feels very different in those two different categories that we're creating today. So with my husband, so fast forward to, we got married, and on our honeymoon, he was finding bone chips in his mouth from radiation. It was an effect of the radiation. And then I was starting grad school at the same time. He had surgery every single semester that I was in grad school.
What kind of cancer did he have? Did he have?
So he's a 3-time oral cancer survivor with
Oral cancer.
like, he never smoked. He never drank. He has no genetic factors. They tested 70 different gene sequences, no genetic factors. So they believe it to be environmental. And he had it a third time in 2017, and we were married, and I can talk more about that at some point. But this was effects of radiation. So before the third cancer, the bone had died. It's called osteoradionecrosis from the bone dying from radiation. But in that, how did I get there? Like, so his cancer has resulted in some other chronic symptoms and chronic fatigue, and he's actually unable to work. It's all related to the cancer and the radiation and some blood disorders that he has now developed as a result. And so with him, sure, he has thought about at times his own mortality. I've thought about his mortality as his wife and caregiver. There are points in that trajectory when that feels more salient with the cancer diagnosis. Right? In 2017, there was a time that I collapsed in my shower thinking my husband was not coming home from being in a treatment center, a rehab facility, actually. That those moments feel like, okay, we have to consider life and death and fear of those dying and death. Whereas now he's in this place where it's like the illness is there. How do you live with that? How do you also not make it the focus of your life? Or is it the focus of your life? And I see that with my clients or him, that at times it does feel it's more present. So if we think about that idea of, the dual process model of grief, what's more present? Are we focused on the illness or the loss? Are we focused on how we're living with this illness and that loss, if that makes sense?
So the dual process being where we lean into the loss, and then other times where we lean into just making sure that we're getting the kids to school and we're eating lunch.
Yeah,
and,
absolutely.
And us going back and forth
Yes.
in a way to cope. All right.
Right. And I think so the trajectory over illnesses looks different for many illnesses. Even if we just say cancer, there are 200 and some diseases that qualify as cancer. They're all very different. And so all of those trajectories look different. I work with a lot of clients with MS. That's very different. So understanding what is quote unquote normal, which I don't think there is, for an illness, for that person, and what is the medical team saying? Like, what can we expect? And sometimes they're not upfront about that too, and that leaves all of this uncertainty. So I do think the common thread between these two categories that we've defined kind of loosely is uncertainty. How do we live with uncertainty of, am I going to wake up and be in pain? Am I going to wake up and have a seizure today? Like, is my medication still going to be working or available, or all of the uncertainty? And how does that impact my life?
So many questions I have. Like, I got my brain's going in like 14 directions because I have so many questions about this. So we have this common thread of uncertainty, which I got to say, from a personal perspective and working with clients who I have clients who have cancer. I have clients who have chronic illnesses. I have clients that are caregivers of people with serious, very complicated chronic illness. And in many cases with chronic illness, it's not just this one illness. It's many different ones. They can branch off depending on the trajectory of it. Tell me if I'm wrong, but depending on the trajectory of it, different medications, they begin to change. Your body doesn't respond to them as much anymore, or you become more sensitive to it, or now you've developed a secondary disease that's coming with it. Now we've got to figure out how to treat that. Oh, but how does treating that interact with treating this? Oh, this, because my medications, mine collide.
Mm-hmm.
And we are constantly in communicate. Like, and that's another thing I want to talk to you about is I don't think that people are taught that they have to be their own advocate,
Mm-hmm.
that I might have to be the one that goes, no, I need you to talk to my epileptologist, my general, my general practitioner, and my oncologist, and my pharmacist. And y'all
Mm-hmm.
need to get up on the same page because a lot of you don't know how these medications interact with each
Mm-hmm.
other. And that's the reality. And we're not taught how to do that.
Absolutely.
And that is frustrating because I mean, if you're really not in the medical field or even the mental health field at
Mm-hmm.
all, you might not be exposed to any of these
Mm-hmm.
things. And who the hell's going to teach you that? No, you're going to
Nobody.
fumble around
Yeah.
and you might not even get the medical care that you need as a result of that. And doctors are treating the symptoms, they're not necessarily treating the patients.
Mm-hmm.
Am I wrong? Sorry, I went on my own.
No, I could say about 1,000 things and
What?
10,000 different directions on that. So,
Do all the
or
things.
the other way around. So, personally, is it okay to share this personal
I
experience?
prefer you share the personal.
Great. So, I was leaving WVU Medicine where I was working postdoc and faculty member, and I was coming back to Pittsburgh where we live. And my husband, that's about the time that my husband was diagnosed with cancer for the third time. And his oncologist at the time knew I was coming to the cancer center. And we had this conversation. I'll never forget, we were in the treatment room, and I was like, I have spent days. I mean, I was thankful that I was between the two jobs, that I had the time, and we had at the time the financial resources that I had the time to do this. But, and this is right, I don't know where your listeners are, but this, I think we're talking about the US health system in this way. But for me, it was like I sat there and I looked at this guy who was about to become the head of the cancer center, and I said, I've spent days making phone calls, and if it wasn't for your nurse being able to say you need to call this person or this person, and I'm still not able to get these answers, and for if I hadn't already had knowledge about how the healthcare system works, like where am I going to go? And I worked at when I went there, I ended up working at 4 locations of the cancer center. That's a whole story for a different day. But the one hospital, which is the women's hospital here, has what are called, I think they're patient navigators or nurse navigators, that they're social workers. Maybe it's patient navigators. And they do end up being that point person. Like you don't know who, you need to call this person or we need to get you this. And they are really good at finding and connecting you with the resources you need or having the doctors talk to one another. But none of the other hospitals in the same hospital system had that. And then for my husband, who was, it's an oral cancer, the oncologists aren't technically called oncologists, they are ENTs. And they have a great survivorship clinic there. I worked there for a while. It was multidisciplinary. And that is the closest they get to this coordinated care. So if you are a caregiver or a patient without any knowledge of the medical system, you are spending time trying to figure out the system, figure out what you need. And time sometimes is of the essence. You might not have the time to figure out what you need and how to, who am I supposed to call and do, are they going to get me in? And what do I say? And that I think can be really frustrating. And a lot of the work I do, I will say, and I actually just told the class that I'm teaching this last week, I think in my work, sometimes I take on some social worker skills that aren't typical of a psychologist. This was especially true when I was in the cancer center because if I know, like, I'm not going to be like, huh, let's talk about how you feel about not being able to get there. Sure, we're gonna have those conversations, but if I know who you need to call, I'm gonna give you that information because I've been there. Like I know what it's like to not know how to navigate. So I think that is a failure of our system. But I will also help my clients advocate. You don't have to wait till that next appointment that's 6 months from now because you're having a symptom today or your appointment's next week. It's okay to call your medical team and say, I'm struggling with this X, Y, or Z. Like, can I talk to somebody? They're on call for a reason, right?
Mhm. So sounds like this is regardless of whether or not this is a chronic illness or a terminal illness, these are issues
Mm-hmm.
also that come up,
Yeah.
engaging the communication, finding somebody who's a care
Mm-hmm.
coordinator, being able to say, oh, I don't need to wait until my next appointment. Because I
Mm-hmm.
definitely have clients in my own experience who are like, well, I have an appointment in November. Yeah, but right now you're noticing that there's an exacerbation, like for example, with MS, with the relapse remitting,
Mm-hmm.
right? And you're having relapse symptoms you weren't when you made the original appointment.
Mm-hmm.
Um, it's okay that you reach out, and they aren't taught how to navigate that.
Mm-hmm.
How do you feel that people who are struggling with chronic illness, how do you feel about oh my gosh, there's so many questions about that. Um, or what do you think? Like, how do you feel? Like, feelings or thoughts. Um, what are some of the biggest challenges emotionally and psychologically for them? We can talk about the system
Mm-hmm.
too, which we've already begun, but
Mm-hmm.
I'm kind of curious as to what you think, and including your husband, because it sounds like his is kind of like on the cusp. There's a little
Mm-hmm.
bit of like this, the going out of remission and then coming out, and is this chronic? Is this not? So that seems to be a little bit on the cusp.
Mm-hmm.
But what are their biggest challenges for people who are navigating living with a chronic illness?
I think a lot of unspoken fear can happen. Uh, I'm wondering if you also have this experience with your clients with chronic illness, but there's this part of that I'm just going to wait till that appointment in November can be systemic, right? That's when I got the appointment, but also I don't want to know, right? There's this fear. Well, I can live and not think about it until November. I might think about it every day, but at least it doesn't feel certain, which I always help people see that, yeah, you might not have that answer now, but you might not get that answer then either. Wouldn't it be better to know now and then we can cope with what it is here? But let's explore it first. Like, what is that fear? A recurrence in cancer, for example, is really scary because before you heard you have cancer, that meant nothing to you. You hear it. Now you know how terrible what followed that was. I don't want to go through that again. But what would it mean to know that now? To know that there's a plan, to know all of the things. So I think fear is a big one.
It's like a fear of knowing and not wanting to know. It's like both
Yeah,
ways. Like you're screwed
exactly.
either way.
Right.
You know, I want to
But
do
what
something
if
about it. Go ahead.
what if I find out and I know and it's like, okay,
Hmm.
it was nothing and I can trust in that. I think that's part of it. As an aside, you have the person that you're outside gardening, you're sore, you come in, you're in a lot of pain. Oh, that must be cancer, right?
Mhm.
Like, so I'm starting to see this through the lens of it's this terrible thing. So helping people also see that perhaps it was you were gardening and you pulled your back. Maybe we don't have to worry yet. But that's a different question that I did that you didn't
But
ask.
it's no, it's a good point because I was thinking and you're saying that and I'm going and I'm sorry to bring this back to me, but in thinking about the leukemia, one of the main things I noticed was that I could not keep my eyes open. I was absolutely what I would come home and just crash, and that's just not the way I operate. So now, if I get tired and I want to have a nap, it's almost traumatic.
Mm-hmm.
Like I'm afraid to be tired in the middle of the day.
Mm-hmm.
And then I'll go get my bone biopsy or whatever, and it comes back normal. It's like, oh, okay, I could have taken a nap and I didn't have to be fucking
Mm-hmm.
terrified that I'm going to be hospitalized inpatient for another
Mm-hmm.
30 days. So, again, that cusp of is this chronic? Because it's kind of ambiguous, right? I don't
Mm-hmm.
know if I'm going to be able to ring that bell at the 5-year mark.
Mm-hmm.
So right now it kind of feels like here. I know I'm not
Mm-hmm.
getting rid of the epilepsy, so that's there. Now, how do I live
Mm-hmm.
with something I know is never going to go away?
Mm-hmm.
And then you've got if I would not have responded to the treatment and became terminal, that's a whole different ball game of what I have to live
Mm-hmm.
with. So this chronic illness, other than fear, because I can see that, I've definitely
Mm-hmm.
seen that. I'm working with people with that, and I'm experiencing it. Oh, I've also seen, and tell me if I got this, but I've seen sometimes with people, let's stick with chronic illness, right? With chronic illness, almost take on the identity that comes with that chronic illness.
Mm-hmm. So I think this
Does
one's
that happen?
challenging. Yeah, of course. But what does it mean to them? Like, why are we taking on that identity? And for some people, it's not that they're taking on the identity, it's that the people are putting that identity on them. So this is, and I'll talk about both cases, but I'll start with my husband,
Mhm.
who he's permanently on a feeding tube. He cannot swallow even his own saliva, so he cannot eat. He's had 2 surgeries that they're called microvascular free flaps. They've taken part of his fibula out of each leg because he had it twice to reconstruct his jaw. So his balance is off. His fatigue is there. He's not able to really exercise. Definitely cannot eat or drink anything. You know, that's a lot. But
That is a lot.
people will ask him, and you can hear it in the tone, and you can hear it sometimes in the words, but they'll ask him how he's doing, and it's not like how I'd be like, "How are you doing today, Chrissy?" It's more of they don't ask him always; they'll ask me, like, "How's he doing?" And you can hear it's we just assume he's now this cancer patient, right? Even though he's not had active cancer in quite a while. He's not doing great, but he's not, it's not cancer. And a lot of my clients will say the same thing, that it's people will see me as someone with, well, actually, they'll see me as an MS patient, or they'll see me as a cancer patient, or they'll see me as someone with POTS, or whatever the chronic illness is. They see me as the patient. I don't want to be the patient. I want to be Angela, who so happens to have cancer, right? Like that's what I don't have cancer. But if I did, I would not want to be the cancer patient. Who am I separate from my diagnosis, separate from my illness? And parsing that identity out can be hard. But for some people that do take on the identity, it's comforting, right? Like, what's the benefit of having the illness or having this identity? And it might be connecting. People may have not come around you in that way. That felt good, right? Having that support and that love and all of the things. Perhaps it's, if I let go of this identity, then what? Then am I the healthy person that could lose my health again? Like, what is behind taking on this identity? And so, are they taking it on, or are other people putting it on them? Those are two different experiences.
So if it feels like somebody, like people are putting that on them, so instead of them looking, let's look at a chronic illness like, I'll just, again, I'll use epilepsy. Oh, she's epileptic versus she's a person with epilepsy.
Mm-hmm.
If we take on the identity of I'm epileptic, what can, like, how do we know if that's working for us or not? Like, what if, like, like you had just mentioned, maybe I'm getting some support,
Mm-hmm.
by saying I'm epileptic, then, all of a sudden people are like, oh my, we want to, take care of you. And that makes sense. But some of us may rail up against that and be like, no, that's not the kind of, I don't want to be seen as that. I want to be seen as a person with epilepsy.
Mm-hmm.
What do people, how do they, how do they do that? How do they, shift from not really wanting that to be their identity definition to being seen and feeling like themselves
Mm-hmm.
as well as I am a person who has this chronic illness?
Mm-hmm. What if they don't want to be seen separate from that?
Yeah. What if they do? Like, what do they do? Like, what if I've got, like, for example, we've got people that are listening here and they're going,
Mm-hmm.
no, I don't want people to say, oh, I'm, she's an Alzheimer's patient, for example, as opposed to a
Mm-hmm.
person with Alzheimer's. Like,
Mm-hmm.
what if they don't want to feel that way, but yet people are coming at them and treating them
Mm-hmm.
that way? What do
I
they
think
do with that?
it's hard, right? So how do you set a boundary, right?
Yeah. Okay.
Of like, I appreciate that you're asking me how, or that you have concern for me as a Alzheimer patient, or that I am a lupus patient.
Mm.
There's more to me than that. Could we talk about today? I know that you want to ask how I'm doing, right? Similar to your sandwich around couching grief. So I know that you're curious about how I'm doing. When I hear you ask me how I'm doing today, or like only asking me about my health, it makes me feel like you don't see me as a human being. Could we talk about instead how the kids are doing, or even the weather? Like, could we go for a walk and focus on something else? How do we interact and not talk about this? I have a lot of patients who will set that time aside. Like, this is the time, even with their spouse. Like, this is the time we're going to talk about all of the things we normally would talk about. That is a disease-free conversation. We're not, the boundary around the time is important.
Hmm. The boundary around the time is important. It's an interesting statement because it feels timeless at
It
the
is
same time,
timeless.
right?
Yeah, yeah.
So we got this boundary around the time in the midst of something that's timeless.
Mm-hmm.
So another dynamic that I've seen is people often pushing against not wanting to be compliant with their medications.
Mm-hmm.
Maybe because of side effects, maybe because of what it reminds them of.
Mm-hmm.
What's your experience with seeing, or do you see that as
Mm-hmm.
well? And what are your thoughts about why that might happen?
So I recently was working with someone who definitely did not want to be on any medications. She's never been on medications in her life, and the fear around side effects, the beliefs that she had around medication in general, just being a bad thing or showing weakness or it makes sense. Like, let's understand where you're coming from before we like, make some blanket statement about why are you railing against this? What would it mean? Like, are you afraid that you're never going to get off the meds? I think we see that in traditional mental health work, right? I don't want to be on an antidepressant the rest of my life.
Mhm.
Like, I shouldn't need it. The shoulds are often there. Like, I should be able to do this, or I don't want to lose my hair, or
Mhm.
I'm afraid of needles. Like, those are all very different reasons why I might rail against the medication recommendation. So I think I can't give you a blanket answer as to like what do we do with that other than let's help people advocate for themselves in sharing why they're railing against it. Maybe they read that something, or saw a commercial on TV and they think that something else will be more effective, or maybe it's I really just don't understand or want to be on this. Let's talk about what the benefit is, but also what's the danger in not following those recommendations. How do we talk to your doc? How do we help you talk to your doctor
Mhm.
about that?
Yeah, it was just you just read my mind. I think there's another part, and that's the financial component.
Absolutely.
We've got some people might have the financial resources. We've got other people who their chronic illness is so debilitating that they're not working, and then maybe they're on, government, types of, Medicaid or even maybe on Medicare, and half the freaking medications aren't even covered. So here
Mm-hmm.
they are. There might be more effective medications that are on the table, but they can't get anywhere near them because they don't have the financial
Mm-hmm.
aspect of that. How do you think? I mean, have you seen that play out, and how do you think that impacts people with chronic illness?
I mean, you hear often about financial debt around medical treatments, right? I have seen it play out. The hospital where I worked had a foundation that would help people get their medication. So in the cancer center, there was assistance for that. Even when I was at WVU Medicine, there's some assistance programs for that. They don't always cover everything. Interestingly, what I learned behind the scenes is that oftentimes the oncologists or the physicians with other chronic illnesses can help have those conversations with the pharmaceutical companies to change the costs or trials are oftentimes what people will go to, but that has its own risk too. So I think it's an unfortunate state of our medical system. You shouldn't have to mortgage your house to be able to afford your care. So I would encourage people to talk to the social workers wherever they're getting their care and see what other programs or options are there. How do we make an appeal to the pharmaceutical company or the insurance company or if you're underinsured, I don't know what that means, but like how do we advocate for you?
Yeah,
Social
people are
workers are your
not.
friends.
Yeah, they are your friends, but they're overworked and often underpaid and
For sure.
stretched too thin, right? And unfortunately, can't always like kind of forget that they're in a system that the patient doesn't know about. I think it's taken for granted, not on purpose and or in bad way. It just life. What would you say are some secondary complications and implications for people with chronic illness? And then eventually, I do want to talk about caregivers because this is a whole other layer of this, right? But
that
With
part might make me
yeah,
teary, though. So
yeah.
just when we get there.
Well, eventually I want to make you cry. That's terrible.
What are friends for?
Hey, man, I'm here for it. Did you bring your tissues? Because by the way, just so you all know, she just interviewed me, and I cried like for half the freaking time. You can watch her video of that. You can have fun with that. Listen to that. But it's not being me. This sounds I'm being vindictive. I'm not. I just hear you. I'm here for it. But secondary losses, what might
Hmm.
those, and what the implications of those are? Because I'll give you an example. One of the things when I was doing some research uh, on people with chronic illness was like not being seen as a person with uh, like sexuality. Like it's all
Hmm.
of a sudden, it's like, this kind of physical intimacy with our partners might be impacted, and this important need for human touch and not only intimacy, but yes, like sexual engagement. I might not even have the freaking energy, desire, or anything with my body, but that's an implication. That's
Hmm.
another loss, right? So, and we will talk about grief of all this. I swear to God, we're going to come back to that. But what do we? What are some secondary implications for
Well,
chronic?
let's start with that one, and I'll try not to get tearful around this one myself. But think about, okay, so I'm a caregiver for my husband. Sometimes that's been more active than others. His cancer has aged him. In fact, we go places and sometimes people think he's my dad. He's 18 months older than me, but I used to think I looked younger than I am. I don't know if that's true. You don't have to be kind and say yes. But he definitely looks a lot older than I do, right? So, from an attraction perspective, don't know if he's going to listen to this. That has changed, right? Like the inside person has not changed, and being attracted to him there is fine, but he looks very different. So there's that aspect, and then I think the secondary loss. This is a big secondary loss for a lot of people. There are books written about how chronic illness affects sex and intimacy. For caregivers um, in our current medical system, their insurance wants you in and out of that hospital as fast as they can get you in and out of that hospital. Sometimes that means going to a rehab facility. My husband was in one for mid-July through end of August, beginning of September in 2017. And that was long, and that was after a decision that I had to make. I'll come back to that in a second. But the some of that care, the things that I have had to do to take care of my husband with all of his surgeries, have included things that I never thought I'd do. And there's a reason I'm this type of doctor and not a medical one. I don't do gory things, but as I'm saying this, these images are coming into my head of having to change his dressings. That's the word. Change his dressings when he had part of his leg put into his jaw, and using leaking holes that have happened as a result. Hair growing in his mouth because your leg grows hair, and then they put your leg into your mouth. Like, these things affect intimacy. He's missing most of his tongue. Without being graphic, that affects intimacy in
Sure.
multiple ways. I can't tell you the last time I actually kissed my husband in a like really intimate way. So these are, I think, sure, they could be called secondary losses, but as I'm talking about that feels very much like a primary
Hmm.
loss. And I don't, you know. And at the same time, he never lost his interest, right? So it's like we're talking about this from the caregiver side. There are certainly patients who go through illnesses and treatments, and libido is a loss, right? Think about having a hysterectomy or, you know, any of those surgeries. And mastectomies, I work with a lot of women who have lost interest, and, you know, their
Mm-hmm.
breasts were part of their intimacy and their sex lives, and that is affecting them. And sure, many of their spouses or partners will say it doesn't affect them, but that negates the fact that it affects the patient, right?
Mm-hmm.
Like, oh, I accept you as who you are. Great. And let's validate that it impacts the patient who's struggling with this too, right? So I
Mm-hmm.
don't know if that answered your question, but I think that is a primary loss in some ways, right? I guess it's technically a
No, I
secondary
think I think
loss,
it
but
is. I think you're making a really, good point. It's really, I mean, and I'm glad that you're clarifying that. And then you may have gone into remission and survived breast cancer, for example, but
mm-hmm,
like you said, you have you have lost your breasts and decided not to have reconstructive surgery, which I can understand, why not?
mm-hmm,
But what if your spouse was like really into your breasts? You know
mm-hmm,
what I mean? Like, I know my husband was really into my hair, loved my hair, is one of the reasons why I was attracted to him. When I went bald and was bald, I, I couldn't even imagine wanting
mm-hmm,
to, and love the man. I I was attracted to him. I did not feel there was any way he could be possibly attracted to me. Not to mention, my body felt like shit.
mm-hmm,
I didn't really wanna be touched. I looked ill. I felt
mm-hmm,
ill. Um, the idea of some of the ways that we would be in that way, intimately, like, I couldn't imagine feeling attractive enough to be able to enjoy being physically intimate,
mm-hmm,
even if I was feeling better. And, I think that I imagine people with chronic illness whose bodies have changed so much are going to have to navigate some of those processes, and then
mm-hmm,
to, grieve that. And if you've come from a place where maybe you were healthy a lot of your life, and then let's say that you ended up with Lyme disease
mm-hmm,
and something like all the changes that happen in your body, the adjustments of I was living a healthy, active life that, y- everybody's Lyme disease kind of presents itself a little bit,
mm-hmm,
but, and every like the life I had, I have to grieve the life I
mm-hmm,
had